Dear viewers, welcome you all to our show Orthopedic Solution Academy Shoulder Clinic. Hope you all are well with your friends, family, and definitely with your patients. Dear viewers, we discuss with a shoulder topic in our program, and today our topic is a very important topic, that is portals and position of shoulder arthroscopy. That is the basic shoulder arthroscopy topic today. And the speaker is the one and only Dr. G.M. Jahangir sir, the pioneer shoulder surgeon of Bangladesh. I would like to request Dr. G.M. Jahangir sir to join with us.
Thank you, Dr. Ashraf. Thank you for invitation to joining in this program.
Thank you very much, sir, for joining with us. Dear viewers, we have another learned academic expert with us. That is Dr. Rajeev Raman, sir. Hope you will connect with us in the coming part of our program. Dear viewers, we all know that the most difficult part of shoulder arthroscopy is the position and the portals. And today we will discuss about the portals and the position of shoulder arthroscopy. Sir, would you please share your screen and start your magnificent presentation, sir?
Okay. Can you see and hear me?
Yes, sir. You are completely visible and perfectly audible, sir.
Okay. Shoulder arthroscopy procedure is a common among the arthroscopy in all joints of the human body. So, before knowing the details of the shoulder arthroscopy, it is utmost our duty to know the shoulder position and portal, through which we can do a lot of arthroscopy procedure in shoulder joint. Dear viewers, you are welcome to our today's shoulder arthroscopy positioning and portal. Change my? Where is change?
No, sir. The slide is not changing, sir.
What happened? It is hanging.
Yes, sir. It's hanging. Better you restart again, sir.
Okay. Because I do not outside. Now you can see my skin?
No, sir. Just share your screen, sir. Again, share your screen.
Okay. Stop sharing. Okay. Yes, again I go for sharing my screen. Present. Yes, share screen. Share screen. This, I think this entire screen. Share. Can you see?
No, sir, not yet, sir. Yes, sir, it's coming. Yes, sir, we can see your slide now, sir.
Okay. So, shoulder arthroscopy position option. There are two positions for the shoulder arthroscopy: lateral decubitus and beach-chair position. Actually, each position has its advantage and disadvantage, and it also depends on the surgeon preference, which is convenient to each surgeon. It depends upon its efficiency in the respective position of the patient. So lateral decubitus position, in this position we put the patient in lateral decubitus position, and some important requirements for the lateral decubitus position. You can see patient is on the table and there is two traction. One is longitudinal traction, another is lateral arm traction. And longitudinal traction usually 40 to 70 degree abduction, and it requires weight about 10 pounds. And this patient is tilted posteriorly to 15 to 20 degree to create the glenoid holder, as because our glenoid is retroverted 10 to 20 degree. So it's required posterior tilting. You can see this is the after draping the position of the patient. This is anteriorly and this is the foot end of the patient. So this arm is longitudinal traction. But here there is no lateral traction is shown because we do put a bolster or sheet of cloth under the arm during the procedure. Lateral decubitus position, it has some advantages like increased access to the glenohumeral joint and subacromial space, control amount of arm traction. That means some patient needs 10 pound or 4 kg, some patient need 3 kg. It depends upon the bulk of the patient or BMI of the patient and healthy of the patient, all this. And lateral decubitus position can easier access to the superior, inferior and posterior shoulder joint and allow surgeon operation with arm at side for increased comfort and decreased fatigue. As because in case of this position, the arm is always abducted. It creates an fatigue and uneasiness to the surgeon. And lateral decubitus position has some disadvantages like NITOR traction device, arm holder, greater chance of positional related injury like several bony prominence come in contact with the table during the lateral decubitus position. And traction injury, especially brachial plexus, will give the more abduction and longitudinal traction and and peripheral nerve injury. When lateral arm traction, it causes injury to the nerve like median nerve, ulnar nerve. And also lateral decubitus has its complex draping and needs complex padding, and it is difficult to conversion to an open procedure when open surgery is needed. Sometimes in arthroscopic procedure, it is difficult to control the bleeding and to access. In this situation, we go to the open surgery. So in lateral decubitus position, to do the open procedure in the glenohumeral joint, it is a bit difficult. And next is B-chair position. In this position, upper body elevation about 60 degree and hip flexion you can see about 40 to 60 degree and knee flexion 30 degree. And in this position, the head and neck secured in a cup and there is shoulder draping should be free and also includes all the arm and arm is fixed in a holder and allowing a different types of movement like external rotation, internal rotation, and abduction and adduction of the shoulder by the arm, arm holder, which is in this lateral position. And at the patient is keep at the lateral position of the table, so there is totally free of the shoulder from the table as well. And it helps to do the surgery in which chair position easy. In which chair position, there are some advantages like good clinical examination under anesthesia, because I have already mentioned that there is the shoulder is free and arm holder can rotate in 3-degree position. Normal vertical orientation of the shoulder anatomy, better access to anterior and superior glenohumeral joint, well suited for subaqueous procedure like rotator cuff repair and facilitates draping. That means easy draping and allows rapid conversion to an open procedure when it is required. And disadvantages like poor visualization of the posterior and inferior glenohumeral joint, water logging at the at the tip of the scope, which causes haziness of the monitor to see, and some risk of hypotension and cerebral desaturation when visceral position is used for shoulder arthroscopy. Now come to the portal. There are several portals for shoulder arthroscopy, and among them, some are very important. I discuss here. We'll going for discussing this portal in the some next slide. And posterior portal, if you see the that is shoulder and marking, that is anterior part of the shoulder, this is posterior part, this is lateral part of the shoulder. Anterior you can see that is coracoid and posterior. So posterior portal, which is called primary viewing portal, and it is located 1 to 2 centimeter inferior, 1 to 2 centimeter inferior, and 1 to 2 centimeter medial to the, this is posterolateral corner of the acromion. This is posterior portal, and this portal may pass between the infraspinatus and teres minor or through the infraspinatus muscle substance, and it is directed towards the tip of the coracoid. You can see here that is corrected. In this still picture, you can see that is posterior portal and there is anterior portal. So we can see the video how the posterior portal posterior through the posterior portal is created and what are seeing through the posterior portal. In this video you can see this is posterior and this is anterior, and this is a skin created at the 1 to 2 centimeter inferior and medial to the posterolateral corner infrared, and hand is directed toward the tip of the carotid. After palpating the head and glenoid and enters the trochlear cannula to the joint space through the posterior portal or viewing portal. And next come to the anterior-inferior portal. Anterior portal, again it is seen, it is anterior, that is lateral, and this side is posterior. This anterior side, this is coracoid, tip of the coracoid, and anterior-inferior portal is created just inferior and lateral to the tip of the coracoid. This level is anterior-inferior portal, and localized with a spinal needle using outside in technique above the subscale tendon. On sometimes it is done from outside in and also inside and out. Used primarily for instrumentation and suture anchor placement for anterior banker repair. You can see this portal. This is localization of portal just above through the rotator interval above the subscapularis tendon and below the bicep tendon. You can see here this is the glenoid fossa. So first anterior inferior needle, it is created in this position that it do not interfere with the upper border of the subscapularis tendon. Just we can enter to reach the trajectory of the glenoid rim and labrum and to lower fold of the inferior glenoid margin. You can see this is a through this video we can see that how it's created from the anterior aspect. You can see the tip of the needle inserted, and through the after insertion needle within the root is introduced, then portal dilator. After removal of portal dilator, respective cannula is introduced. In this position in anterior inferior portal, usually 8.5 or 8 millimeter portal cannula is introduced for instrumentation, suture anchor placementation, and knot tying. Next, come to the anterior superior portal. We can see that is the lateral margin again, that is posterior margin of the acromion, and here is a tip of the coracoid. This is the marking of the anterior inferior glenoid rim, and this is the desired anterior portal. It is usually located 1 centimeter above and lateral to the anterior inferior portal. Uh, or it is at the around the anterolateral margin of the anterolateral side of the anterolateral margin of the acromion, enters the joint directly above or anterior to biceps tendon, and used for viewing instrumentation or shuttling. You can see there is a two portal arthroscopic view, that is anterior inferior and anterior superior portal, and it's between the anterior to the, this is bicep tendon, anterior to the bicep tendon. You can see here also through the steel fixture there is posterior portal through the trocar cannula and anterior two portal, anterior inferior and anterior superior portal. In video we can see the how the anterior superior portal is created. After creating the anterior inferior portal, anterior superior portal is created. There is two portal here, you can see. Again the same way, after Indian needle, then Usinja rod, then portal dilator, and then insertion of the cannula, inferior cannula. Let's come to the lateral portal. Lateral portal is another important portal for creation, for repair of the rotator cuff and subacromion decompression. In this steel fixture, you can see this is the posterolateral corner and anterolateral corner of the acromion. So this is anterior portal, this is posterior portal, and this is lateral portal. And this portal usually 2 to 3 centimeter distal to the lateral margin of the acromion, either mid lateral acromion or junction of the anterior 1/3 and posterior 2/3 of the margin, as because it corresponds to the posterior border of the clavicle. This anterior 1/3 and posterior 2/3 junction or mid point of the acromion. Localized with the spinal needle while being in the subacromion space. That means we can view the subacromion space through the posterior portal and inside the inserting lateral lateral portal inside the needle. Then, if required, then it is cannula used for subacromion decompression and RC repair. Mostly subacromion decompression and rotator cuff repair. It is usually created. The lateral portal. Another important portal that is called posterolateral portal or portal of Wilmington. This portal is usually created 1 centimeter anterior and 1 centimeter distal to the posterolateral corner of the acromion. This is posterolateral corner. So this portal is Wilmington. It is placed under the supervision from posterior portal with the help of spinal needle. In this figure, you can see that is a posterior lateral portal or portal of Wilmington is created, and it is used for instrumentation during slab or RC repair. This is, you can see, that is posterior labral tear, posterior superior labral tear, and this is used for insertion and repair of the slab tear as well as rotator cuff tear. Another portal, this is called superior portal or portal of Nebiazir. This is also used for the repair of rotator cuff. It is created at the corner of supraspinatus fossa and localized 1 centimeter medial to the acromion and between the clavicle and spine of the scapula. You can see here, this is clavicle and this is spine of the scapula, and this is the point for the creation of Nebiazir portal. And you create this by showing through the posterior portal, and the Nebiazir portal is created. It is penetrates the trapezius muscle and pass through the supraspinatus muscle belly, enter the joint medial to the supraglenoid tubercle, used for slab or rotator cuff repair. So this is the all about the portal for the diagnostic as well as treatment of shoulder pathology. we can see as a video overall creation of portal. I can do from the viewing the posterior portal, then anterior superior, anterior inferior and anterior superior portal is kit. Initially, portal site is identified by the needle, then within the rod, portal dilator and cannula inserted. And cannula is required according to the instrumentation, and maybe cannula size either 8.5 or 8 millimeter or 5.5 or 5 millimeter. And thanks for attention.
Thank you very much, sir, for your nice and excellent presentation. Sir, what do you prefer for the young learners? The position of the which position you prefer for the young learners?
Can you hear me?
Yes, sir. Can you hear me, sir?
Yes, I go.
Sir, can you hear me, sir?
Yes, yes, yes. Please
Sir,
repeat the question.
sir, which position you prefer for the young learners, sir?
Yes, it is a very good and authentic question. Actually, it depends upon the surgeon or young surgeon, which is he is trained up and convenient. Basically, some each position has its advantage and disadvantage. So, but particularly glenohumeral Bankard repair is better to do in lateral decubitus position. And rotator cuff pathology should be done through the visceral position. So, for the learner or young surgeon, it is better to do the interarticular pathology, especially Bankard, and so it should be done through the lateral decubitus position of the patient.
Thank you very much, sir. Sir, you have told about many portals, but all the portals are mandatory, or there are some important portals in case of shoulder arthroscopy that we all know about the important portals.
Yes, it is very important. Usually, we think what are the pathology we will go for to manage it. Like when we go for Bankard repair for recurrent shoulder dislocation, then we create three portal: one posterior viewing portal, and anterior two portal, anterior superior portal, and anterior inferior portal. So these three portal are important for Bankard repair. And also by two portal, anterior inferior portal and posterior through posterior portal, Bankard repair can be done. And for rotator cuff repair, usually posterior portal, lateral portal, and anterolateral portal. These three portal were important for rotator cuff repair.
Thank you very much, sir. Thank you very much for your nice and excellent presentation. Dear viewers, we will connect with you in the coming Friday with another topic of shoulder. Till then, hope you will be well and get connected with us. And I want to thank Raj TV and Malleus ENT Specialized Hospital for sponsoring our program. And I'm Dr. Tanvir saying bye-bye to all of you today. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.